So I'm going to put something on his head so I don't get my hand deep prep on. I'm going to reach underneath.
No.
I
guess one Frank doesn't equal the other Frank.
Whoa, gentle.
Frank's already equal.
I'm going to grab the levator in the upper trap. I'm going to grasp and lift. Grasp and lift and work my way up. I'm going to come all the way around. I'm going to grab the tissue on his left side in my hand, grasp and lift. It's a nice soft tissue technique working across the fibers of the levator, upper trap, posterior cervical, and suboccipital muscles. Stabilize, grasp, and stretch. Okay? So that's the lateral neck fascial. And then we're going to do the deep neck fascia. We'll take this away. So you put this underneath. It doesn't go all the way down to the upper thoracic. You put it just under the occiput, so you have a little tunnel here, or a bridge. The next technique, we take it away. And I'm going to be in the upper thoracic, and I'm going to rake, like a garden rake, through from the upper thoracic into the upper cervical area. Coming paraspinally, trying to get to the deeper system, right to the occiput, and give a little traction to the skull away from the neck. So fingers are up towards the ceiling, and then release through the neck up toward the occiput. And open up that occipital-mantle space a little bit. If you find something in the upper back, upper trap and levator is tight, you can do a little oscillation right in through there. Find some knots, some trigger points, some ropiness. Try to release that. This table is ready to go. Right in through there. And then continue on through the neck, along the facets, through the multifidi and rotatories, right up to the suboccipital and the occipital area. Little stretch. The third one we did in massage, so you remember this. There were 3 phases: inhibitive occipital distraction. So I'm going to put my fingers flexed at the PIP joints under the inferior nuchal line. Specific compression. I'm going to support the weight of his head in my palms. Inhibitive occipital distraction. So as I maintain the pressure, he starts to get some inhibition and the muscles release. I then take him into more occipital flexion. The rotation that Anders was talking about is really important because we're going to do a number of techniques. We're going to try to address forward head. And we want to give the patient the sense that the rotation of the occiput in the sagittal plane is occurring around the ears, the ear axis. The chin is moving towards the hyoid bone, just above the Adam's apple, and the head is rotating around an axis running through the ear. That's the movement. So we release the tension in the occipital extensors, and as it gets soft, we slide the back of the head along the table into occipital flexion. Phase 1. Phase 2, we do a condylar decompression. We release the tissues out to the sides by supinating our forearms and bringing our elbows together. And we direct our forces from medial to lateral on either side. And the last phase is to get them off the palms so that we have flexion at our MP joints. So less surface area, more pressure. Pressure equals force over area. So less area, more pressure with the same amount of force. And as I get inhibition, I take his head into more occipital flexion. Chin towards the hyoid, rotating around an axis running through the ears. And as we do this, this is going to restore the range, so now we can get the strength. You can't train the deep neck flexors if the posterior occipital area is tight, because you're going to get inhibition through the arthrokinetic reflex. If the occipital condyles can't slide back because they're stuck forward in extension, every time they try to bring their head into flexion, you're going to get inhibition anteriorly and facilitation posteriorly. So you've got to free that up, as we've done all over the body. We did the medius, the maximus, the hip. We did the lower trap. It's the same thing here. We've got to restore occipital flexion before we can expect normal strength of the deep neck flexor. We've got to get the range back. And then back to our palms, and then down. Okay? So let's start with the lateral